Hello, good afternoon. My name is Nancy. At this moment, I'm going to summarize the conversation with my patient about end-of-life care. The patient was a 85 years old African American man who was brought to the clinic by her daughter out of concern for his health signs since he had stopped taking his medication. The patient is diagnosed with 3 chronic conditions. He suffered from type 2 diabetes mellitus, hypertension, and chronic kidney disease stage 4. The patient is continuing his medication after an episode where a dizziness spell induced by hypoglycemia caused him to hit a tree. Since then, he has been concerned that achieving glycemic control may predispose him to low blood sugars and further accidents. Upon discontinuing his medication, he started experiencing symptoms consistent with hyperglycemia. I asked the patient who would be their praxi and why. The patient indicated that he would want his daughter, the one who brought him to the hospital, to be his praxi. The patient justified this choice by the fact that he has a good relationship with a particular child. Furthermore, the daughter is accustomed to taking care of him, is calm and patient, and has medical knowledge since she is a nurse by profession. How did the patient respond? The patient was hesitant about discussing his end-of-life care. He argued that even if he had fallen behind in his self-care, he was determined to get control of his health and that he aimed to live a quality life for many more years. Was there a family member involved? Did the family member support the conversation or did they resist? His daughter was present during the conversation. She is the healthcare agent of his father. While she does not make the decision for him, she is responsible for helping him implement his wishes regarding his health. She also lives with him and helps care for him by ensuring that he takes his medication, leads a healthy lifestyle, and helps him manage the several clinics he attends for follow-up care. Besides, she brought him into the clinic on that day out of concern for him. The daughter supported the conversation, perhaps because she has been exposed to the conversations in her nursing practice. She even helped her father to understand the importance and need for end-of-life care planning when he showed hesitation. Were there any barriers to completing the discussion? There were some barriers regarding decisions of some of the wish statements. The patient had not made up her mind for some of the issues, perhaps because he did not know that he needed to make such decisions. What documents and choices did the patient already have completed? The patient had not completed any documents. However, he was sure that he wanted his daughter to be his healthcare agent. Patient goals. The patient goals is to live for as long as he can, taking advantage of all available procedures, treatments, and interventions that only lengthen his life but also improve his quality. Interventions. The plan was to resume the patient on the previous treatment regimen with minor adjustments. An education intervention was also implemented to help the patient understand the importance of some of the recommendations given to him. Barriers. The patient was not prepared for some of the questions. Patient Self-Determination Act. This is a federal law that ensures that all competent individuals exercise their right to express their preferences and propose the use of life-sustaining treatment and interventions while they still have their mental capacity. The patient recorded and communicated his wishes using the patient wishes statement form during the end-of-life care planning conversations. Living will and advance directives. The patient had already prepared a living will and deposited with his family lawyer. The patient also reported that he had filled the relevant documents regarding power of attorney and deposited them with the lawyer. The healthcare praxis was the only advance directive yet to be completed. Durable power of attorney for healthcare. The patient's daughter had the durable power of attorney of healthcare. Consequently, she had the responsibility and authority to make medical decisions on behalf of her father in the event he lost his cognitive capacity to make and communicate such decisions. Medical orders for life-sustaining treatment. These are records of a patient's wish on the procedures, interventions, medication, and treatment that can be used to sustain their life if the attending physicians determines that absent of these procedures, the patient is likely to die. The patient was already undergoing dialysis on account of his chronic kidney disease. The patient was also clear that he wished to be hospitalized if it was necessary for optimal care. In the same breath, the patient wished to have any necessary procedures performed on his unneeded, including cardiopulmonary resuscitation, blood transfusion, intubation, hydration, surgery, artificial nutrition, and the use of implantable cardioverter defibrillators. These wishes were aligned with his goals of leading the longest possible life. Decision-making capacity. The decision-making capacity refers to the cognitive ability of an individual to understand the prevailing medical situation, its implications, and the available options, and make and communicate the decisions on the way forward regarding care processes. Healthcare praxis. This is an individual to whom the responsibility and authority are given to implement the wishes of a patient in the event of cognitive incapacity. The patient named her daughter as his healthcare praxis. Palliative Performance Scale and Karnofsky Scale. Karnofsky Scale facilitates the classification of patients by their functional impairment. The scale is rated from 0%, where the patient is dead, to 100%, where the patient is fully functional, with no sign of disease and complaints. Lower scores on this scale indicated a lower likelihood of surviving serious diseases. The Palliative Performance Scale facilitates decision on the eligibility of patients for hospice care by enabling the care providers to notice a functional decline in a patient. A rating of 50% and below indicated eligibility for hospice. However, a rating of 70% for oncology patient is enough to confirm eligibility for hospice care. Thank you.